Hello, my name is Mary Beth Hines. I'm so excited to be the host of Keys for SLPs Learning from Legends series in honor of ASHA's 100th anniversary. Today, I'm joined by a co-host for this episode, Christina Liem. Here are the financial and non-financial disclosures. I am the host of Keys for SLPs podcast and receive compensation from Speech Therapy PD. Christina Liem is an employee with the ENT Physicians Group at Loma Linda University. She receives compensation from Speech Therapy PD for co-hosting a podcast miniseries. Edie Hapner receives an honorarium from Speech Therapy PD for participating as a podcast guest. Christina Sapienza receives an honorarium from Speech Therapy PD for participating as a podcast guest. Okay, and now that we have our disclosures out of the way, here are our learning objectives. Explain how voice and voice disorders have evolved through the years. Explain key research that has impacted voice and voice disorders in speech-language pathology. Describe the future direction of research and practice of voice and voice disorders.
Thank you, Mary Beth. And now I would like to introduce our legends in the field of voice, Dr. Edie Hapner and Dr. Christine Sapienza. Edie Hapner is the George W. Barber Jr. Foundation Endowed Professor of Otolaryngology, the co-director of the UAB Voice Center, and the director of the Division of Hearing and Speech in the Department of Otolaryngology at the University of Alabama, Birmingham. With over 40 years of professional experience, Dr. Hapner is an ASHA Fellow and an Associate Fellow of the American Laryngological Association. She has co-founded 3 interprofessional voice centers and co-developed Forte Voice Therapy. She has served on numerous committees and boards, including the ASHA Board of Directors, SIG3 Voice and Voice Disorders, co-chaired the 2022 ASHA National Convention, Alabama Voice Foundation, Alabama Dystonia International, and is a founding member of PAVES, a committee developed to facilitate the Board of Certification in Voice. She has published over 90 peer-reviewed articles and book chapters, is the co-editor of Voice Therapy Clinical Case Studies, editions 4, 5, and 6, and developed the voice curriculum for MedBridge Incorporated. Dr. Hapner notes that her most significant achievement is mentoring 22 consecutive voice and upper airway concentric speech-language pathology clinical fellows and 50-plus graduate and undergraduate student clinical and research interns. Dr. Christine Sapienza is the Executive Vice President for Partnerships and Development, former Provost and Senior Vice President of Academic Affairs at Jacksonville University. She joined JU in 2013 as the Dean of the College of Healthcare Sciences. Prior to her role at JU, she served as chair of the Department of Communication Sciences and Disorders at the University of Florida. Dr. Sapienza has authored and co-authored over 125 published academic works, including Voice Disorders, 4th edition, a widely used textbook in speech sciences and communication disorders, and is currently working on the 5th edition with co-author Barry Hoffman. Dr. Sapienza is known as the co-inventor of the Expiratory Muscle Strength Trainer, or EMST 150 device. She holds a PhD in speech science from the University at Buffalo. Welcome, Dr. Edie Hapner and Dr. Christine Sapienza. I'm so excited you are here. I get to ask all exciting questions and learn more about your career and pick your brain today.
Love it.
Great. Good to see you, Chris.
Good to see you, Edie.
Well, thank you both for being here. And we did find out before that you are, we know you're colleagues, but you're also friends. So that's wonderful. We're just so happy to have you both with us. And I'm really
and if you listen closely, we're both very old.
Oh my gosh, I know. He said over 40 years. I didn't want to tell her how much over. Sorry.
I love it. So we're going to take turns asking questions, and I'll start with our first question. So for fun, can you tell us something about yourself that people may not know? And we'll keep it short for the sake of time today.
Well, I'll go first. I guess for me, people probably wouldn't know that going to college wasn't really on my radar, as a young person. My parents didn't go to college. Most of my siblings didn't go to college. And I tried to think of the fastest way to get done with school, and never in the world would have dreamed I'd have a PhD and work in higher ed.
There you go.
Wow.
My clinical fellows told me to tell you everything from I owned a pet duck once to I have a sorting hat in my office. But the truth is, I'm going to tell you that I always wanted to be the weather girl, and that's what I started out as in college. It's a long story.
Nice.
You don't know that.
Dr. Hapner, actually, I can see it.
Right.
Well, thank you both for sharing, and we are so happy that you did choose the field of speech language pathology. So let's talk a little bit about your journey, what led you to SLP, your early career, why you chose your area of interest, and eventually what led you to become an ASHA Fellow.
Go ahead, Edie.
Oh, thanks. Well, I ended up in speech pathology, honestly, and because I didn't end up being the weather girl. And it's interesting because my roommate was getting a communication disorders degree. And I had watched her for a few years and thought, well, this is kind of fun. My mother was a stutterer, and my father had a head injury that nobody really knew except the family. And I always found just it very interesting. So that led me to speech pathology and becoming an ASHA fellow. Man, that's crazy, right? How that even happens. It happens with years of probably volunteerism primarily. And I think that one of the things to tell everyone, if this is something that you're interested in, is that volunteering and meeting, I mean, it's how I met Chris. I don't even remember probably what committee or something we did together, but it is probably one of the most enriching and rewarding experiences, and really actually helps you advance your career and your knowledge more than you would ever know.
Yeah, that's very, very well said. I think a similar story on the ASHA fellow, it's, you're being recognized by your peers. And so the only way that your peers can recognize you is what is it you're doing for the good of the field, right? And to Edie's point, that volunteerism is key, being involved in the national organization, being involved in your state organization. And, whether you're out working boots on the ground, patient day-to-day care, or doing science, it's a recognition of your contribution to your field. And so getting involved helps you meet a lot of different people from really all aspects of the field. For me, I was surfing as a freshman in college. I took a course in anatomy and physiology taught by Elaine Stathopoulos, who probably a lot of people might not know that name, the younger generation. And honestly, it was a mentor recognizing me as a student in her classroom. And I think that's the power of mentorship. I don't think I ever would have chosen speech pathology had somebody not wrapped their arm around me and said, hey, I think you kind of, link in with this pretty well. And I was fascinated by anatomy and physiology, fascinated by neuroanatomy and neurophysiology, and fascinated by the sciences. And so I think the power that Edie and I both have experienced and extended to other people is mentorship really matters. And that's how I got involved in the field.
Wow. Thank you. Thanks for sharing that.
Well, I just have to give a little plug right here. You guys don't see Yumi, but she was my mentor. So
oh, wow. There you go.
Yes,
absolutely.
it goes a long way.
Mm-hmm.
That's amazing. I love that. Mentorship is so, so important. Speaking of, let's dive into the field of voice in speech language pathology. The question is, how has the treatment of voice disorders evolved in the field of speech language pathology through the years, and especially throughout your careers?
Yeah. Go ahead, Chris.
Oh gosh, you're talking about an individual who, graduated in the late, 1980s with a master's and then a PhD in 1993, we didn't know a whole heck of a lot. We did know a lot about the science. We began to understand really about how the vocal folds vibrated, how they were a multi-layered system, how you needed to be very careful as a surgeon not to do significant damage to the very sensitive, epithelia and lamina propria of the vocal fold. We were just learning really how not to do damage. We really, at that point, had not been separating out types of voice disorders. We really weren't, I don't think, Edie, really talking about the neurogenic and neurologically involved types of voice disorders. So I would say, I watched it evolve from being more sort of shooting in the dark as a clinician with really, think back, even then, dysphagia and airway management was not a mainstay in our field. Now we're at a point where we are really have an understanding of the anatomy and physiology and high detail with the advent of high speed, stroboscopy and digital endoscopy. And so I just think we're smarter, we're mathematically smarter about how the voice works, and we're physiologically smarter about the voice work. And I think Edie can talk more about how that's evolved into how we treat it. That's really what we know about it from the mechanics and the science of it.
Yeah, I think, I started treating patients in 1981 is when I finished my master's degree. PhD came 15 years later. But the difference is that somewhere around the early 90s, like Chris said, this world of us being able to look at vocal fold motion and understand pliability, understand lesions, and then other technologies opened up. We could assess respiratory function and its impact on voice production. And then there was this field that started around the same time that we started getting smarter and more informed, and that's called the field of laryngology. So laryngology, otolaryngologists, as Chris said, they started learning that there were ways to operate on the vocal folds that didn't cause scar, didn't cause a problem with your voice worse than what led you to surgery. And then they found us and we found them, and that partnership of understanding that we each have a role in the diagnosis and the treatment of people with voice and upper airway disorders, for me has been a game changer. And for me, that happened probably around the same time, right? Like mid 1990s.
Yeah, and that to hang on your point there too, I think now what we're seeing, Christina and Mary Beth, is that we're not just, when something back then occurred, a surgeon would treat it, there was no communication with the speech language pathologist, the patient went home and kind of figured out how to resolve it on his own or not. Now, today, we're dealing with looking at the voice as the science and the art of voice together. And so we are prophylactically trying to exercise it, right? And kind of prehabilitate it. And then we go through the actual process of the treatment, whether it's phonosurgical, behavioral, or otherwise. And then we care about what happens afterwards, right? The recovery period. And I'm thinking back, Edie, remember when people went on vocal rest like forever?
Weeks or a month.
And we could be like, just be quiet. Just be quiet. We don't want anything to happen to the vocal folds. And now we find out, we look at a randomized clinical trial today and it says, hey, you don't really hardly have to rest your voice at all.
Mm-mm.
In fact, you should be using, your voice. So that's how much to me the field. I mean, literally, I remember people being on vocal rest for 30 days.
Right.
And drink a lot of water. Drink a lot of water. Don't talk.
And when do you think that changed?
Well,
the interesting,
go ahead.
The interesting thing about voice rest post-surgically is that it's still evolving.
Mm-hmm.
So as we understand, we are still finding out things about the vocal fold morphology. And so it's even recently that there was a paper published, maybe the last 10 years, that said, should we do 3 days? Should we do 5 days? And But really, people aren't even talking about much more than that. What do you think, Chris? The last.
Yeah, no, you're right. I think there was a paper that just came out in 2024.
Mhm.
And I'm sorry that I don't have the citation right in front of me, but you can look it up, the beauty of the internet, and go into your resources. But that really looked at a randomized clinical trial between the 3 and the 7-day periods, and found that the 3-day was, showed better improvement than the 7-day. But it always evolves. And I think, not to jump too far ahead, things like dosage, frequency of treatment, the length of time, the types of tasks, all of those protocols are ever evolving. And I think that's the fun of it right now for speech pathologists, because we have learned so much about the biomechanics and the science and the acoustics and the aerodynamics that we can certainly talk about, that now the fun is all about the modification of treatment and treatment protocols and assessing the good outcomes that we now know we have in order to test whether something works or not.
It's fascinating though, because, I mean, there's different stories about how long it takes the royal we, meaning the world, to start implementing what science has found out. So it's not uncommon for us to get a patient in the Voice Center who had surgery with another surgeon, outside in the community, and we're still put on several weeks of voice rest. Or
misdiagnosed, because look at how many people, we now are in the world of high speed, digital stroboscopy, right? But only for so many practices or groups, or where folks can afford it and have been trained in it.
Yeah.
So you're still going to be potentially, as a clinician, faced with the reality that you may have more knowledge than others that you're working with, and are going to have to impart some of that on the patient care with, communicating with your multidisciplinary team. But we've learned so much about how lesions, what they are exactly, and how they react to things because of that instrumentation advancement. But Edie's right. Sometimes you'll get a patient that's still been through, 5, 6 different diagnoses before they've come to you.
All right. Well, when considering the assessment and treatment of voice disorders, and we've kind of hit upon it a little bit, but what pivotal research in your experience has significantly impacted treatment and assessment in speech pathology?
You want me to go?
Yeah, sure.
We kind of answered this a little bit. I think for me, my life changed. I mean, as a clinician, when stroboscopy became part of my practice, because now, and high speed is a whole other game changer, because as you know, stroboscopy is essentially a little bit of an optical illusion, although it's the best clinical tool we have besides our ears and our eyes as clinicians. But stroboscopy, prior to that, somebody may have a voice problem and we would look at their vocal folds and not see scar or not see sulcus or an adynamic segment. And then that led into something Chris talked about too, which is more and more understanding, because of being able to study these, of the kind of what the life of a different lesions look like. So, I mean, we still have new named lesions, whether you buy it or not. We have, everything used to be a cyst, and now we've got different names for things. And maybe it's not a cyst, maybe it's not a polyp, everything's not a nodule or nodules. There's no such thing as a nodule. There's fibrous masses, and fibrous masses don't get better. Nodules get better, fibrous masses don't get better. So everything changed. For me, all the pivotal research in the early 90s around laryngeal imaging has made a huge difference in decision making for me.
Yeah, and then I will add to that, which was incredibly impactful during the time I was studying, and I think really important for the generations that come after us or who have come after us. Look at the work And if you don't recognize the name, then you're not paying attention to the legacies in voice. Edie and I kind of chuckle when you introduce us, but legacies, we are standing on the shoulders of people that we admire. Ingo Titsa, okay, who applied mathematical modeling and the application of physics to help us understand more about the myoelastic aerodynamic theory of voice production, and said, okay, how does it actually work? It's a mechanical system, driven by a pressure head developed by your respiratory system, and then shaped. The sound, right, is important, but it's ultimately shaped by the supraglottal cavity, and that supraglottal cavity shape can actually make your voice harder to produce based on what's going on up above it, right? And those were things we didn't know until he started to apply some models to it. So I think for me, it was learning and understanding the complexity of the aerodynamic characteristics that shaped our voice. And even now when, I talk to students and I say, how do your vocal folds work? How do they vibrate? How does it get started? How does it get sustained? How does it stop? Why is the muscle, and I'm so much into exercise-based treatments because, point of fact is we're dealing with a skeletal muscle system in the vocal folds themselves, the respiratory system, supraglottic tract, et cetera, that all can be exercised. Obviously the basis of a lot of what Edie's therapy is about. So I think that combination of understanding that voice is a one of the most complex biomechanical systems we have, focused on aerodynamic drive, and then shaped so much by muscle action that can become so impaired with different types of diseases.
Yep.
So fascinating. I just love listening to the two of you. So thinking then about the future versus where we have come from in the past, what further research would you like to see developed to advance the assessment and treatment of voice disorders?
Go ahead, Chris.
Oh gosh, I think what would I like to see versus well, we already know sort of what's happening, and I'm gonna defer a little bit more to Edie here because she's probably more on top of the phonosurgical approaches than I am. But Edie, I mean, we're already starting to see injections of stem cells and into our human anatomy for regeneration of damaged tissue. We know so much more about hyaluronic acid and its role in vocal fold vibration and vocal health. Edie, if you don't mind, I'll punt a little bit of that over to you, but I think we're going to see a lot more with, the way that insurance is working and how to incorporate voice therapy through telepractice models, through teaching caregivers how to implement things in the home. We've got to figure out our instrumentation and be working more with, there are a lot of app-based things out there already that people can use. We have fallen far away from the instrumentation that I used back in the day. We got to be using our phone. We got to be using app-based biofeedback systems that are out there for our patients. And we got to keep inventing, like the innovation curve has to keep going up in terms of what we can provide to our patients for that biofeedback. And then the last thing I would say is we've got to get the vocal folds healthier in people. We've got to educate people to keep that system healthy. I'll say one thing. We care so much about the way our arms and our legs work, but we don't take care of the very thing that protects our lungs from penetrating and aspirating material into our airway and producing what it is that we communicate, sound. So we've got to get more attention and funding for preventative prophylactic health of our vocal folds.
I love that.
No kidding, right? I mean, I was literally talking to a group of people with Parkinson's disease right before I got on this call, and it's saying to them, your job is to stay one day ahead of the Parkinson's disease. And the way you do that, we have to stop thinking that we're just these little, my mentor, Frank Wilson, used to call us glottal voyeurs, meaning we just, it's a terrible term, right? We just look at the larynx. No, we do so much more. Because I talk to them about sleep and nutrition. And hearing health and and exercising the body. But to not, I mean, because I think the two of us could probably just talk about this stuff forever. I think two super cool things on the ENT side is looking at the biome of the vocal folds. They're looking at the biome of their gut. What makes people have healthy guts and not healthy guts? And so why does somebody have chronic cough and their vocal fold, they're coughing their heads off and their vocal folds look pristine white? And then another person's coughing the same amount of time and their vocal folds are ulcerated. Why do people react to the same toxin or environmental, whatever,
Right.
differently? And that's, on the medical side. On the speech pathology side, I am so excited about something called the RTSS. Okay, it's the Rehabilitation Treatment Specification System, and I may have that wrong, but it's really close to that. Jared Van Stan and Jeremy Wolfberg are working on this. And what it's teaching us is that people need to stop saying, and I did voice therapy. It's like it's a single entity, right? It's not a single entity. So we write these articles and they say, oh, so they had this surgery and then they did voice therapy. Like even any of the four of us would do the same thing with a patient. So it's looking at the ingredients that make up voice therapy, understanding it's not a single entity, and saying these, you touched on it, Chris, when you were talking about frequency, intensity, and duration, because that's part of it. But looking at, I did this and I did it for this long and this intense and this often, and they got better, versus I did this and they didn't. It's not just comparing therapies, one to the other. It's talking about what are the ingredients that make up the therapies.
Yeah, I'm gonna ride a little bit, and just a little bit on the soapbox too, because I do think that as the field has progressed, people have sort of sloughed off their understanding of the anatomy and physiology and the biomechanics of the voice. And so if you are the type of clinician who just wants to go into the voice therapy toolbox and apply that, I find there's always, Christina and Mary Beth, a big loss when you as a clinician do not thoroughly understand how the apparatus works. And so then you are not making the right decision, for the patient. And I can bet and guarantee that if I were to quiz 50% of the people, either on the call or in a, that they may not be able to intricately describe what is it exactly that the mechanics of how the voice works and the physiology. And so much, I think, Edie, of what you're doing and others in positioning the right techniques only work. I always say to people, they only work as well as you know how to use them right. And you actually understand, how the voice works. So I just say, that it's a science and it's an art. And I think Johann Sundberg, who is one of the great legacies in the field of voice, who, if you don't know him, comes out of the Royal Institute of Technology in Stockholm, Sweden. And, he was the one that really taught us about the Singer's Foreman and taught us so much about the blending of the science and the art of voice. And I say the same thing for voice therapy. It is a combination of the science and the art. So like anything else, I think what's been fun for us is, as an expert, you take the time to delve deep and read literature. And if you don't want to read, then attend things like this and listen to podcasts and listen to webinars and such. I mean, that's what our field's so great about. We can find these pieces of information from so many different types of sources.
And then be a bit of a skeptic, right, with what you hear, because just because somebody says it doesn't mean it's so, right? So just take it, apply it, see if it works. If it doesn't work, ask why.
I have an interesting story about that. I was a graduate student, Edie, and knew nothing. And probably my supervisors didn't know much more than I did at that point either, in school. And a gentleman comes in, he has bilateral vocal fold paralysis, can't adduct, can't close the vocal folds. And I'm supposed to work on him as a graduate student clinician. Well, here's the thing. I start working with him and I'm able to produce sound, and I'm able to take that sound and shape it into speech. Well, goes back, gets scoped, and I get condemned by an ENT doctor because they said that you got his ventricular folds vibrating, not his vocal folds.
Mhm.
And I didn't really know any better until I woke up like 5 years later and said to myself, I was never wrong, because I used the only apparatus that was viable to produce sound, but I didn't know any better how to speak against what somebody had said to me. So, that's a great story to realize, you were only using what you could, which were the false vocal folds, to produce the sound of shape and speech. Did it sound pretty? No. Did it sound, the way that a normal vibration would sound? No. But it was all he had. At that point in time, there was no thyroplasty. There were no phonosurgical techniques. There was no augmentation. So that's, I think, just to show how much the field has evolved, but also show that sometimes, like you said, somebody might tell you you're doing something wrong when actually it works, or sometimes you're doing things people want to sell to you, and you've got to be a little bit more skeptical about that.
Right?
I love the thinking out of the box approach.
Have to.
Yeah. Yeah.
And do you think that that patient really cared? He just wanted to speak, right?
Yeah, he wanted to be, he was a lawyer. He wanted to be able to vocalize, and that's what we were able to do. And again, I think back, that particular professional, didn't say to me as a speech pathologist, congratulations, you actually got found a voicing source for him, right? So I think it's just again a good example of really understanding your anatomy and physiology, and leaning on what's going to work. That's not a wrong thing to happen if it produces a source of sound.
Can I say to this too? I think sometimes we forget that actually we have degrees in communication. So if we can't make beautiful voice, can we help somebody find a way to communicate? Because I have a broken ankle right now. So getting up and walking across the room, that's really important. But you know what's more important? Sitting here and talking tonight and being able to communicate. And so I think sometimes we get so caught up with, oh, I can't do voice therapy, but maybe teaching them ventricular phonation is teaching them to communicate. Or, Chris, the patients that come in and they're going 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, because they have bilateral vocal fold paralysis and they only can have 3 syllables or 3 seconds. And you know what? Can they order dinner in a restaurant doing that? Heck yeah. So what's wrong with it? It's the same thing. It's remembering that we're communication specialists.
Well said. Well said.
Such a good point. Okay, so our next question that we had planned, again, we've kind of brushed on it a little bit, but I'm going to change it. So besides stroboscopy, what do you think are the most significant changes that you have seen in your career? Might be a philosophy or a theory that has been debunked. And while you're thinking, I want to tell you something that I don't know if you saw. One of our participants said, "This is the best CEU class I have taken in years. Thank you."
Thank you.
Thank you to that participant.
Well, there's been a lot of stuff that's, I don't know if it's debunked per se. I think, as I said before, I think we're structurally becoming better clinicians. We're following our instructions better, like simple stuff, guys, like we have to know when things are effort dependent tasks, and, I've so many times I've seen people do maximum phonation time and they don't do it correctly. SC ratio, they don't do it correctly. They're good little measures if they're done correctly. If you actually breathe up to 100% of your lung volume before you start the task or instruct the patient consistently. We fail and can fail our patients so terribly just by not following protocol instructions. So I don't know if it's debunked. I think we've just become a better clinician over time. I really do. I think we're much more confident in who we are in the field. And Edie probably wouldn't say it. We're pretty smart. Not us. Our voice colleagues that work alongside the multidisciplinary team. We know. I'll tell you this. When I was a doctoral student, I went to an otolaryngologist and I said, I want to know more about anatomy and physiology and neuroanatomy of the voice. And I want you to teach me with your curriculum. And he looked at me and he said, you guys know more than we do. You're taught more than we are in our own curriculum because they're taught across a larger spectrum than we are. So we are becoming a very confident field. So I don't know if it's debunking. I will say, I mean, in terms of the stem cell research, in terms of the biome stuff Edie's talking about, in terms of the types of lasers we're using now, boy, they've advanced. We're getting to the point where the lasers and the cutting and the tissue preservation is so much better than what it used to be in the old days, when people would go in and hack out a focal nodule and then it became, a little bit better. And then this type of laser, then that type of laser, now a blue laser. So that's really evolved, hasn't it?
100%. I mean, so the development of phonomicrosurgery, which is exactly what you're talking about, along with laryngologists, has actually given us patients postoperatively that we can work with. I always said to otolaryngologists, if you don't give me an instrument to work with, you can't say voice therapy failed. Because you've got, so I think one of the things that we've learned as clinicians, and we are gaining confidence, and I know it's a hard thing to do, but people refer patients to us for our professional opinion. And if our professional opinion is somebody is not a candidate for voice therapy, we've got to have the wherewithal to tell our colleagues, I don't want to hear, oh, it's not going to hurt anybody anyway. Sure it is. It's financially a problem. It's emotionally a problem if it doesn't work. So I think one of the things that has really evolved is our ability to determine who are good candidates for voice therapy. And then to tell our colleagues, I may need a little help from you before voice therapy. Maybe you need to inject them and then I can treat them. Or, right? Or, I work with someone who developed the superior laryngeal nerve injection. And there are some cough patients that have been coughing for so long that I say to him, okay, let's do it this way. I know that behavioral cough suppression therapy works, but I wouldn't mind a little bit of help from you. So give them an SLN injection. And then when they come back in 2 weeks, I can say to them, what % better are you? I mean, I've heard 80% before. I like that one, right? I don't have as far to go. So I think like you said, the phonomicrosurgery, I think the moving from symptomatic voice therapy, like if your voice is too low, make it high. If your voice is too high, make it low. No, we don't do that anymore. We want to know, why is it too low?
Right.
So I think that was only in the 90s that happened.
Oh gosh, it still happens. It still happens today, still happens today.
What about Botox? So I'm older than Botox. I'm also older than MRI, so let's not even try and do the math here, okay, guys? So,
I'm not saying anything.
Okay, sit there quietly. We both have grandchildren.
And you are lucky to have grandchildren.
We are. Anyway, I think, I used to cry with patients with laryngeal dystonia, the old spasmodic dysphonia. I used to sit and cry with them because we could do so well in a therapy session, and then the door opened and everything fell apart. So Botox is not an exact science. As a matter of fact, there's people it doesn't work for, but the people that it does work for, and then we can add a little voice therapy if it's even needed. I think that was a huge breakthrough in that neurologically, that movement disorders population.
And that's where too, I think we have evolved too, right, Edie? I mean, we know more, Mary Beth and Christina, about what isn't spasmodic dysphonia?
Good point.
What different, there's so many categories of tremor now that are been defined and are really unique. So the classification, Edie hit the nail on the head. I mean, and she said jokingly, it's not just a cyst anymore, right? But it's really important because we have evolved tremendously because of the vision and the sight that we're now able to get because of stroboscopy and other. We know exactly what the diagnosis is, and we know that some things aren't treatable with behavioral voice therapy. My God, we used to be doing behavioral voice therapy with things that couldn't be remediated because we didn't know. So, I mean, we should be really proud of where we are. So I think it's the visual field that we've talked about. It's the phonosurgical complement that we've talked about. It's the prophylactic sort of performance. It's understanding that it's a muscular system that we're working on. There's so many things, my God, I mean, that have contributed to the advancement of where we are today that I think I forgot the question. But yeah, we're in a very, very good place right now.
Yeah.
Can you touch upon, Chris, something that you mentioned earlier, the hyaluronic acid, the role of hyaluronic acid in voice therapy?
Well, it's an important component of what makes up the anatomy of our vocal folds. And so, when you get into understanding the pliability, the flexibility of the vocal folds and types of injectables that we use now, we never understood really what the vocal folds were made up of. We didn't understand it was a 5-layered system for quite some time. We didn't understand that the layered system vibrated differently at each of the different layers. I think we sometimes, like I said, we forget that the bottommost layer is a muscular system that you can't open and close without the integrity of skeletal muscles working collectively. So it's just what we know the vocal folds are made up of, and that's such an important component of it that we learned about. I think, gosh, it probably was again late 90s, early 2000s that we started to make those discoveries.
And we also learned that if you don't use the larynx, that 5-layer system can also go backwards, and you can lose the layers, and you can become, there's a amazing paper published about someone who had essentially didn't talk for a very long period of time. And after the person passed away, they did a cross-section of their vocal folds, and it was a 2-layered system, which is what babies are born close to. I think babies are born with 2 layers until, I have to remember. Goodness.
About age 4 or so.
Yeah, when the systems start adding more layers, and these layers just give us the beauty to our system, right? And so understanding that and finding replacement products, they don't have that all worked out, but that is going to be amazing when that happens.
That's right.
So we are sitting at a very exciting time with all this knowledge up until now, and with the possible development of further knowledge for the future. So the question then becomes, what further changes or developments, if any, would you like to see in our field? I think we kind of touched on that a little bit, but any ideas?
Yeah, I don't know I'll use the word people are throwing all over around today, right? AI and artificial intelligence. I don't know what it's going to create. I mean, certainly I think it's going to probably be able to create databases of a variety of different voice types, where it would have taken us 10 years to create those different voice types to study, by waiting for the patient to come in and now we can just type in the characteristics that we want, the identity, the age, the this, the that, all the characteristics, and create these samples that we're going to be able to analyze and learn from. I think that's going to be pretty extraordinary. I think people are going to start doing more with data banks of tissue banks and learning more about how the tissue regenerates. And then we already, talked about the stem cells as being are really, there are papers coming out now to the person's question on the chat, coming out now about the use of stem cells to regenerate vocal fold tissue and help minimize scarring. So that's just going to continue to accelerate in the people that are doing that work. So I think those are some of the things that, are going to happen. I have one that's it's kind of humorous, but it's actually true. I want to know what we're all going to do when we live in microgravity. When we all start living in space and skeletal muscle deteriorates, due to microgravity. We have no way of exercising, our muscles of our respiratory system and our larynx and et cetera. So let's not think of, where we are now, but I just had a grandchild that was born, I think, 2025, he'll graduate from high school somewhere around 2040 something. I don't know where the heck we'll be, but
Right.
chances are we're going to be living, and I think Edie touched on this, different environments that we can't even dream about right now. And all of those things we already see with astronauts that have been in microgravity environments for a long period of time, the toll it takes on their body. Well, but believe me, they're not going to report on what's happening to the breathing system and all the systems that we're so intimately involved in, but it is taking a toll. So those are some fun things to think about. But on the positive side, I think AI, I think stem cell, I think the continuation of these high acuity laser systems, that they may end up giving you, Edie, as a speech pathologist, a byproduct of really healthy tissue for you to work with.
Wouldn't that be nice?
After phonosurgery.
Yeah. I think that more and more in office, less invasive kind of procedural things are going to happen, less going to the OR, more, going to the ORs. It's risky business. I don't care, no matter what, it's risky business. And so I think that the future hopefully will hold more office-based procedures, which will get us actually involved sooner and in rehabilitating people.
And there's so many otolaryngologists that we could name to give shout outs to that have brought us, to this point. Somebody who was really impactful during my time is Dr. Peek Wu, and he taught us a lot and began to show us, the impact of office-based procedures. It's not, they're so much more advanced even then, but back then he was, I think, educating us as speech pathologists about office-based procedures and about patient-centered voice therapy and voice care. Yeah.
Voice care. Mm-hmm. Yeah. Dr. Wu never missed coming in and listening to a speech pathologist do a presentation at the Voice Foundation.
A lot of, that's what that word respect, there really has been a mutual respect now between the two fields that it's so enjoyed by those of you practicing today.
I just have to tell you, I stress about this a lot. Christina probably would not be surprised at all to hear me say this, but I stress about our field and as speech pathologists. And, we're trained, oh my goodness, I'm can of worms. We're trained as generalists, right? But the world is moving so quickly into specialty areas, it's hard to keep up. I couldn't keep up. I always tell people, I know about this little piece of real estate. You can ask me about that. Don't ask me about a lot of other stuff. But I think a lot about our future and how we're going to train our students, and Christina knows this, train our clinical fellows and set up our practices to hold hands with our physician and other healthcare colleagues, because I think the world is really going to be that a lot of advanced practice providers are going to be doing most of our daily medical care, right? So how are we going to move with them? And I think about that a lot, and I don't have an answer, but we're going to have to get it fast.
Well, Edie, somebody had put in the chat, they were interested in the introduction about the possibility of you working on a certification. I think maybe a minute on that. Not that I want to be the host, but I did see that come in the chat, and it might be a good time based on what you just said.
Not really. So what's happening, and it's been happening, Joe Stempel was the first chair of this committee, and I was trying to remember exactly when it was. I was sitting in California, so I think it was 2017. Oh, it was 2017. So 2016 and 17, ASHA funded, that's kind of, it's a funny term, nobody got paid, but I think provided us somebody at the national office to start developing a voice specialization, right? Like there's swallowing and there's fluency and there's things like that. So that has actually been going on. It started with having to think of what makes somebody a voice specialized speech pathologist. And then Christina and I have been working on for many years with a group of about 35 other people. How do you define a voice specialized clinical fellowship? And now people are trying to figure out, well, how do we start teaching our graduate students early to actually, those that are interested, to actually get really specialized in advanced training. So right now, where this is at is I was part of it for about 7 or 8 years, and I am not now. It is Rita Patel and Susan Tebow, and I wish I could remember other people. Julie Barkmeyer Kramer may still be working on it, but they are actually working on the test now, which means it's coming, and there will be a voice specialization. So yeah, I think that's the future. And then I wonder if that's going to hold more advanced training in voice for clinicians who want it. I hope that was an answer.
Did you want to touch a little bit about PAVES, Dr. Hapner?
You want me to?
I think that's actually a wonderful thing to introduce to, yes.
Well, I never have a problem talking about PAVES. PAVES stands for the Pathway to Advanced Voice Education and Service. And it is a grassroots, people are welcome to join. It is a grassroots group of people that started in 2018. It really started with Julie Barkmeyer Kramer and I being tasked on that developing the voice specialization, tasked with figuring out what your resume needed to look like to apply for voice specialization. And we said, well, just like all the others, if you're a voice clinician, you can apply, take the test and apply, and, blah, 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 5 years after you're out of graduate school. But if you did a voice-centric clinical fellowship, you can apply in 4 years. And then Julie and I, everybody loved that. And then Julie and I realized we didn't know what a voice-centric clinical fellowship looked like. So we started asking people to work with us and start developing, what does a voice-centric clinical fellowship mean? What does it mean to do a specialized clinical fellowship? What should it look like? What do you need going in, and what should you have coming out? So PAVES is a committee. You can follow us on Instagram. PAVES is a committee that has been working on that tirelessly with no support from anyone but ourselves since 2018. And we're working on how to support supervisors. We're working on how to support clinical fellows. And actually, there's a clinical fellows seminar series every month. They all get together and talk about a topic, which is really nice. And there's a group that's developing a voice specialized evaluation instead of the ASHA generic clinical fellows skills survey. So, yeah.
Well, thank you for volunteering to do that, and such a contribution to our field.
People.
Is it something that ASHA could support?
Oh, Mary Beth, you just asked me the wrong question.
Okay, all right, okay.
No, I'll just tell you that we were not successful in getting support when requested. So we have been supporting ourselves. But I will tell you that the group often presents at the ASHA convention, has every year at the ASHA convention, and now is officially even doing podcasts. And
Yeah.
so, right?
Well, and I think that the way to think about, your national organizations can only do so much, right? And we can have different views on, what the organization serves or doesn't serve. What was back in the early 90s when we started to develop the special interest division groups. And so, the SID3 for voice. And I think ASHA probably believes that they have a curriculum, they're training to a curriculum, there's specialization groups that are out there. I think this is very, very specific to, what you're defining as a clinical fellowship year. And probably it's hard for ASHA to say, well, if I resource that, then do I have to do that for
every
Asia? Do I have to do it? So
Yeah.
it does put us in a little bit of a juxtaposition on how to answer that. But I do, and I think Edie would say, be sure you join the special interest division 3, follow the work of the people that you'd love to follow, and listen to like I said, listen to as many resources as you can. And it is going to be learned by doing. And I think that's why you're trying to make that clinical fellowship year have so many different parts to it. But that doesn't preclude that if you didn't do that you cannot, become a voice. I would make sure you go to Voice Foundation. It's a great conference. There's Sin City, there's so many conferences that we could list that people can go to learn so much. And then never hesitate to email any of us, like we're here to mentor and help and direct people. So always find our emails online and those in the field. This Voice is a very, very friendly group of colleagues. Always has been and has always been very supportive of students and each other.
Promise.
Mm-hmm.
And I, for one, am very grateful for that.
You're part of it.
Absolutely. Okay, I know we're coming up on time. I have one more question here. If it's okay with you, we can go through these last few questions. Anyone who has to leave will still get their full credit for the 1-hour course. So if you have to leave, that's okay. Make sure you complete the course requirements. And especially if you want them for a live course, you need to do that by the end of the day today. So thank you for joining us. And for everyone else who can continue to stay, if it's okay with you all, do you have like 5 more minutes?
Mm-hmm. Sure.
Okay. All right. So can you describe a case study that has been the most memorable or impactful of your career? And it does, you might have 20. Can you just pick one?
Mine is real simple. I was a young clinician just in my academic career, very quickly, complex case of a woman who came in had 20 some odd surgeries for juvenile laryngeal papilloma. There was nothing you could do for the voice. I didn't know it at the time. Her number one complaint had nothing to do with voice. It had to do with her work of breathing. And that's what helped me invent the expiratory muscle strength trainer. We invented it at the University of Florida. It was all because this individual came in post-surgical scar, very limited glottal area, and had complained of work of breathing and was asking a speech pathologist to help her. And I had no idea how to do it. So that's the case that I remember, and that started off the exploration of respiratory muscle strength training.
I love that.
Which
That's
has helped
amazing.
so many people through the years. So thank you. And thank you to that client of yours as well.
Yes, absolutely.
That's amazing.
You want me to say one?
Yes, we would love that.
Because the person I was thinking about is a gentleman who is a CEO of a company and, had a lot of power and clout. And then he retired and went on boards, but wasn't really working all the time, and came in to see me and felt very, very dejected because people couldn't hear him at parties. He felt like when he presented at board meetings that people he didn't have the power and the command of audiences that he had for so many years. And, if he was going to define himself, he was going to define himself as a CEO, and however you think of that. And so very similar to Chris, He came in, we looked at him. He was diagnosed one of the very early cases I had of age-related changes to the voice. I started using what was an evidence-based treatment for aging voice at the time, and he got all done with therapy, and he came in and he said, well, I'm better, but I'm not all the way better. What else you got for me? And I'm like, I got nothing. I got to think of something fast. And actually, truthfully, that was the genesis of Forte. Was having to come up with something because he needed more, and there wasn't more at the time for me to do.
And that's the beauty of innovation. So like if we leave you guys with anything, it's like it might not be out there yet, and you may be the developer, the one who, whether it's a handheld device, whether it's a biofeedback tool, whether it's a new therapy, a different protocol, whatever. Don't rely on just the here and now. Like, we just really want you to be creative and innovative, because I don't think Edie and I grew up in Buffalo, New York, flipping hot dogs in high school, not thinking about a college education, that I was going to co-invent something that's now used around the world. And same for my colleague here, Dr. Hapner. So, like, you just never know what's going to come in front of you.
I worked at McDonald's, Chris.
Yeah, it was Burger King.
Loves iOS. Same thing.
Oh, well, we'll just skip our next question that we had planned, Christine, because it was, what advice would you like to share with new clinicians? And that was
Perfect.
Excellent, Dr. Sapienza. And Dr. Hapner, is there anything else that you wanted to share as far as advice goes?
I think that that there's been nothing more impactful than having the opportunity to work with soon to be 23 clinical fellows and have a very small piece of helping them feel more confident and secure in becoming a clinician during their clinical fellowship year and always. And so if you have the opportunity, I know it's more work. I know it makes you have to do stuff with students and fellows, and then you do your work. And I know it takes more time and it takes more effort. And sometimes it can be frustrating as all get out. But 99% of the time, it is the most fulfilling thing that you can do. And so do it, guys. Just
lift other people up, mentor them, whether it's doctoral students, clinicians. Don't knock each other down, like, lift each other up. And the mentorship that you've described, I've done it on the science side. I mean, that's why when we're not kidding when we say email us, we're going to answer questions, and do the same for other people. People that are learning are afraid to ask. People that are learning are always intimidated by people that are a little bit older than them or have been in the field longer. Don't make them feel that way. Help them along.
So good. You two are definitely pillars, and it's amazing because the innovations that you have both contributed to this field, I use every single day in my practice, every single day. And sometimes I use them in the same session.
There you go.
Or the
As they
same
should be. Yeah. Great.
Chris.
But it's just amazing that you both are sitting here and we get to have you support us in such amazing ways. So thank you.
Absolutely. Thank you for having us.
You.
Well, thank you. Is there anything else that we have not said that you would like to share?
No, we just really appreciate the time.
100%. Thank you so much. This was fun. So
It
good.
was fun.
I don't get to see very often.
I know. So good to see you, Edie.
It's good to see you.
All right. Well, thank you, Dr. Edie Hapner and Dr. Christine Sapienza. We truly appreciate you spending time to reflect on your careers, the field of voice, the field of speech pathology, and be so candid in your sharing. All right. Thank you very much, everyone.